Okay, am I on, Brian?
Yes, you're good.
Okay, good afternoon, everybody. We are really privileged to have Dr. Eileen Hilton today to talk about these vaccines that are coming out that everybody is interested in. It's a short background of Dr. Hilton. She's a graduate of Columbia University College of Physicians and Surgeons, board certified in internal medicine and infectious disease, and is internationally recognized as an infectious disease clinician, professor, and researcher. In 1998, she became the founding CEO of the Biomedical Research Alliance of New York, which is a consortium of academic medical centers. And she was the principal investigator on over 60 clinical research studies including several vaccine trials. And she is a professor of clinical medicine emerita at Albert Einstein School of Medicine and the author of numerous peer-reviewed articles and books. So she knows what she's talking about, and she's going to bring us up to speed on the COVID developments. She's also on Lieutenant Governor's Josh Green COVID task force. She's not an official member, but she participates in the weekly Tuesday meetings and listens and contributes. So without further ado, here's Dr. Hilton. Oh, wait a minute. And if you stick around to the end of her presentation, she has a special treat for you. She will disclose the greatest pastrami sandwich deli in the world that is located in New York. I've been there, and I can tell you it's true. Dr. Hilton, practiced in New York for several decades and relocated to Hawaii over 10 years ago. She's also been our annual speaker on Medicare over the past couple of years, but this year we decided let's have her talk on COVID. Okay, Dr. Hilton, take it away.
Hi there. Hello, everyone. I see a lot of familiar names and faces. I'm going to share my screen and start the presentation. And well, after all the practice of sharing the screen, I don't see up there what we're doing. Hold on a minute. Okay. All righty, I can pull it up this way. Okay. All right, so we are going to do this talk, and we're going to do it from a slideshow and start from the beginning. Okay, here we go. Okay, a little less boring than Medicare, a lot less boring than Medicare, but a lot more technical in ways. So for those of you who've lived through my Medicare speeches and didn't fall asleep, thank you for coming back to another. I'm now going to start discussing COVID vaccines, okay? Before we do this, I'm discussing why we are so worried about having a vaccine. Why is this virus so worrisome? Okay, well, this is not flu. Everybody who says this is just like the flu, it may be just like the flu, but if it is, it's like the flu in 1917 and 18. It's bad. The current COVID fatality rate is about 2%, actually yesterday in the USA, 2.3% globally, and 1.4% yay in Hawaii. That's good. As compared to 0.1% as the US annual influenza fatality rate. So why has flu mortality dropped? Vaccines, treatments, and prophylaxis. And I'm sure that some of you have had flu exposure and possibly been given a drug to prevent it, Tamiflu or something else. We also have Tamiflu as a treatment. And certainly we have flu vaccines every year, sometimes better than others in terms of whether they work. You know, obviously that it's more dangerous in elderly people. This is extremely contagious, and about 10%, it's estimated about 10% of all the people who spread it of the population are super spreaders and are spreading it to 80% of the people who get it. And I don't know if you remember that choir where people were singing and there was the whole choir pretty much got infected, and then the presidential party where most of the party members got affected, that came to the Supreme Court Justice announcement. So it's a dangerous virus. It's more dangerous than we've seen in a long time. And I don't know what just happened here, but anyway, it can camouflage itself. And as it's reproducing nicely inside your cells, which I'll go over at one point, it does quality control and actually proofreads. Anything wrong with its progeny coming out, it fixes it. This is pretty unusual. This is a very unusual RNA vaccine. If you recall, DNA is the building blocks of everything. Okay, it's life. And RNA is another form of the building blocks of life. And it does in a way tell cells how to perform, and I'll go over that. The RNA viruses are viruses that you've heard of. HIV is an RNA virus, which have been noteworthy for being very hard to get a vaccine for. So why is this so terrifying, this actual virus? Well, it doesn't just affect the lungs. It's not for lungs only anymore, okay? It hits the brain, it hits the intestines, it hits the pancreas, it hits the liver, it hits the kidneys, it hits the lungs. And so the GI tract is a biggie. And the first case actually in the United States was a GI case. Why is it able to hit all these things? Well, one of the reasons is angiotensin converting enzyme 2. Usually, angiotensin converting enzymes are used in drugs for the caring for people with hypertension. But they're, for our purposes, we're going to call them ACE2. And they're found everywhere. And actually, increasing risk factors for obese people, they're found more in obese people. So you do not want a lot of this around when this bug comes a-calling. Children have already been noted to have it, much more so now with this surge on the mainland. It's 12% of the current reported cases, which is a lot. But the scary part is 40% of the ones aged 6 to 13 tested positive with no symptoms. So that's a concern. This picture here is of the foot of a child, and they have something called COVID toes, which used to be called chilblains. And it's seen more commonly when a child or an adult is exposed to cold, like snowy weather, etc. They come back in. I remember having something like this when I was a kid. In addition, the scariest one of all is this thing called MIS, which is multi-system inflammatory syndrome in children. And it can hit where all those ACE2 receptors are, including heart, lungs, kidney, brain, skin, and eyes. Not something you want your kids to get. It's rare, thank God, in that case. Long haulers is not so rare. You may have heard of this in the news where people are complaining, like people who have chronic fatigue type symptoms used to complain about fatigue, headaches, shortness of breath, hair loss, all these weird things that are going on up to 8 months now after having had COVID. And it's due to, in many cases, damage that's occurred to their heart, brain, and lung. And they'll have difficulty reading and memory problems as well. So long hauling is not so unusual now. It's just being reported more and more. And the NIH is actually doing a study now looking at people who are complaining of these symptoms to see if they can figure out, one, how to prevent them, how to treat them, and what the reality is whether or not it's really a deal or it's just, some sort of weird post-viral syndrome that will go away. Okay. The biggie is that 40 to 50% of all positives, when they were testing a lot of people, and they did those tests, you drove up, etc., they were asymptomatic. The other thing is we were discussing before the meeting is that transmission is possible even longer than 14 days, and transmission can happen before you show any signs or symptoms at all, and even if you do not have symptoms. These patients, some of them are young, like in their 20s and 30s, have things like myocarditis. I know that some of the professional football teams and college football teams were very concerned about healthy players having signs on MRIs of heart damage, and some of them were completely asymptomatic, but it tested positive. So they shut down some of these games and teams from competing recently. So I'm going to move along to treatments. I'm going to go over this very quickly. We have no cure yet. We do have remdesivir, which is a Gilead product, and that was FDA approved emergently. This stops the virus from replicating and decreases the time in the ICU, which is no small feat. We've got friends that were in ICUs in New York for over 4 weeks, some over 6 weeks. That's unusual. My husband's an ICU doctor. Usually you're in the ICU 3, 4 days, 5, but not that many weeks. It's extremely unusual, and that's what the real terror is having occupied ICUs, and you can't get the patients out because they're intubated or they're really sick and they can't be moved. This dropped the ICU recovery time from 15 to 11 days, which is great. I mean, it sounds like nothing, but it's a big deal. There's also dexamethasone, which is repurposed. It's a very inexpensive drug, and this is a steroid. And this blunts the immune response. Now, some of you may know about this kind of friendly fire thing that goes on. Okay, your lung gets infected, and your body recognizes immunologically this is something weird going on and starts attacking the virus, but it also sees your own lung alveoli tissue as the enemy. So it's like friendly fire. And that's what happens when these people all of a sudden in the ICU really crump, okay? It's almost impossible to keep them ventilated with a ventilator, and that's one of the really terrifying things about the disease. So this drug does nice things for that. We're quite happy with this drug for that. So that was a good find. They're using a lot of convalescent serum, which is antibodies from recovered patients. And our own town has some monoclonal antibodies now that have come in. I think they're from Lilly, but the one that was used on the president was Regeneron's. And it's now being given even for outpatients, IV for mild to moderate COVID. So this is antibodies that will attack the virus that are synthesized, okay? Now, we're moving on to vaccines. There are over 50 in clinical trials, 12 in phase 3. I'm gonna go into the phases in a minute. 2 are already distributed in the world. China in a late phase, but was approved for preliminary use. And in Russia, Sputnik 5 was approved without any phase 3 trials at all. So there's no proof of efficacy at all. So we don't do that in the United States, but we were able to do it relatively quickly, and I'll go into that in a minute. Okay, for the purposes of speaking about vaccine development, it's important to note that the spike protein was identified as a target that we really wanted to go after, okay? And that's this little orangey red thing sticking up here. The spike protein attaches to what? The ACE2. Remember I was mentioning the ACE2, okay? The angiotensin converting enzyme that some blood pressure medicines developed to help with. This is found all over the body, the ACE2. So this spike protein happily runs into the body and starts attaching to ACE2 where it can find it. It enters your cell, it reproduces inside, and it damages and kills your cell. Sometimes it doesn't kill the cell, it just leaves it damaged. So it's interesting, I was just reading about this the other day, that when it gets in, it cleaves off it actually scissors off that little capsule, that little spike sticking out, so it can get in better, and then the cell membrane walls are breached, so to speak, and it gets in. Okay, so that's the spike protein. That's what it does. It gets in, and the virus starts to replicate using your own, all of your own cells' ability to assemble anything, and it assembles virus, and it breaks out and goes to the rest of the ACE2s it finds around. What does a vaccine do? So a vaccine protein is introduced into your body. They give you a shot. It can be either dead or disabled virus, viral genetic material, or a subunit, a little piece of the virus. Once your body sees this, it goes crazy. Little T cells run out, everything tries to kill it, okay? So it simulates an immune response, and it stimulates an immune response. The body remembers and prevents or moderates infection when it sees this again. So if the real deal comes along, it doesn't know it's not the vaccine. It's already got antibodies to the vaccine, so it starts moving in. Okay, both T cells, which is cell-mediated immunity, and B cells, which is humoral immunity, and that's immunoglobulin. And we'll talk about that a little more. Okay, how do we make vaccines? In the old days, old technology was you grew weakened virus in chicken eggs, and that's why they always ask you, do you have any allergy to eggs whenever you get a vaccine? Because specifically flu vaccine, they ask that all the time. Now they can grow it in mammalian or insect cells, very slow. To do the flu virus every year takes 6 months to grow that up and get it ready for dissemination among the public. And they have to do it every year because the flu strains change every year. So they try to guess which ones it's going to be. Half the time it's a good guess, half the time it's not, okay? But they grow up this weakened virus in chicken eggs, and it's a slow process. Plus, the approval of vaccines is a very slow process. So we're moving along rapidly now, as is the rest of the world, because we're using emergency approvals and we're using some new technology. And that is gene-based, using DNA or RNA for vaccine production really fast. 1 week after China released the genome to the world, when they were having all the problems in Hunan, they had a potential vaccine in several countries because it was that quick that they could actually fabricate a vaccine using this new technology. So the newest vaccines, the ones that everybody's talking about, are messenger RNA. That's using viral genetic code. And they use messenger RNA, or they can use a harmless carrier, and we'll get into that. That's the AstraZeneca vaccine. But they code for the COVID spike protein, and they have that in there. So it's kind of Trojan horse, bringing in the spike protein lookalike, you know, actual replica, and so our body can create immune response. The older vaccines use attenuated, killed, or subunits. So let's look at flu. Flu is a whole killed vaccine, okay? And there are whole killed vaccines in development now for COVID. Of course, they're slower because I told you they have to be grown up in eggs, etc. However, they may end up to be the best ones, but it's not clear yet. We've got some pretty impressive data with the newest ones coming out. And then also subunit vaccines, just so you have a feeling of what kind of vaccines you've had over the years. Subunit vaccines include shingles, Hep B. The downside of that, again, time. It takes several doses initially. To fully immunize someone for hepatitis B, 6 months, okay? And then they have to be boosted, etc. So these older vaccines, they were great, they still are, but they took a lot of time. So this is a joke, It's a simplified overview of the phases, 1, 2, and 3. There's also 4, which is post-marketing. But just briefly, phase 1 is first in humans. Prior to phase 1, you have to show animal studies that looks like it's going to work. You're not just allowed to run into phase 1 and start pumping things into humans without documentation that it worked in animals. Okay, phase 1 is very few patients. It's definitely a lot of things in phase 1 that never make it to phase 2. And the same thing is true, making 2 to 3. A lot of them drop out. In phase 2, you're looking at dosing, and you're looking at different doses in humans again, and you're looking at side effects, okay? In phase 3, that's the big stuff, the big thousands of patients in vaccine trials. I did many vaccine trials, and we, at our site alone, enrolled 2,500 patients. That's a lot of enrollments in one vaccine trial. You're talking 30, 40, 60,000 patients sometimes being enrolled in a trial. Phase 4 is post-marketing, and that's to look for things after the thing has already been approved. It's out in the market, people are taking it, and are they getting sick from it? What's happening? Is there any side effects we didn't pick up before? But it's not as confusing as it sounds. It's pretty simple, and very many of the current phase 3 trials look pretty good. So we have choices. Okay, these are the current ones that are really up for, you know, looking at closely. The genetic vaccines, remember I said, were based on pieces of the genome that they picked up. And that's the Pfizer vaccine, which is in partnership with BioNTech and Fosun Pharma, all having been developed simultaneously around the world, and Moderna. Okay, these use messenger RNA, and we'll go into that in a minute. And then there are the vector vaccines. As I mentioned, they're brought in by an innocuous other virus that's been debilitated in some way or another, but it's not going to hurt humans. And they go in, it's like a Trojan horse, and they're carrying pieces of that protein from the spike, okay? And that would be AstraZeneca and CanSino, which is the one that's now being given to the Chinese military. Oh, by the way, I can send people the slide deck if they want, because there's a very, very good site that tells you everything about vaccine tracking. The link is over there. It's from the New York Times. We have a race. I actually won money on this, okay, because I said Pfizer was going to be first. And I thought that for various reasons. They actually didn't accept any money from the federal government. They didn't want to have anything dictated to them in terms of, you know, do this or do that with your vaccine. So they stayed away from that. But Moderna did. And so did AstraZeneca, from what I understand. But at any rate, Pfizer seemed to be leading. Moderna is now coming in second for approval. And they're going to look at these for emergency approval. The FDA is looking at it, I think, on the 7th and maybe the week right after that. And AstraZeneca is also third in probably going for emergency. Okay. The mRNA vaccines, again, to repeat, the genome is used as a recipe for the spike protein. The spike protein is it for those vaccines. They love the spike protein. That's how the thing gets into the cell, and they figure if they target it, great. And fortunately, even though there are 6 different strains already of this bug, it looks like the spike protein is pretty intact as being a target. So it's probably still going to work. They inject mRNA into cell. It enters the cells. The injected mRNA enters the cell. So you get the shot and it goes into your cell. Once in, the strand manufactures spike proteins. And the biggest thing was trying to get that into the cells, because it's a very unstable, which is good in a way, unstable thing, messenger RNA. And our bodies don't like it. You know, they sort of like go, we don't want this. And it will degrade. But they've managed to wrap it in a lipid coat, and they get it in through that cell envelope, and it enters your cell. Once in, the mRNA strand manufactures spike protein. The spike protein break out of the cell, and the body immune system sees it. And remember what I said, it goes wild. It goes, oh, we don't like this. Let's get something, antibodies, T cells, immune system. Let's all go work on this together. And you get antibody. And I don't know why this isn't going forward. Well, go back one. Okay. Okay, sorry. So let's do Pfizer. Okay, it's about 94. Remember I told you these are big studies. It's going to be about 94,000 people in this study. They've had a preliminary review, which is why they're asking for emergency approval. It's got, I think, 94 cases. They were having trouble getting enough cases because remember there was a lull and now the virus is now surging again. Surging is what vaccine trial people like because then you can get positives and you hope they're all in your placebo group, okay? So 94 cases and they found over 90% efficacy. Unbelievable. We are very happy as vaccine investigators if we can get 50 to 60% efficacy. Many of the vaccines you get are only 50 to 60% efficacy. 90% efficacy is fabulous. 95 is unbelievable. So this was 2 shots, 3 weeks apart. Big negative is it needs super cold storage. It needs a -70 to even -90 in some cases. It needs to have that cold chain kept grades, okay? That's a big negative. So places like the United States on the mainland where they have -70s in many of the cities, no big deal. But places like India, Africa, China, whatever, you're going to have real problems getting very cold storage. So I think Kaiser will figure out a way to get it, Pfizer will figure out a way to get it and to have the cold storage work well. There are still questions here, like the safety long-term. What we've seen so far looks pretty good in terms of safety. I'm going to tell you right now, in a vaccine trial, usually 2 months after the trial has stopped, in other words, you've gotten your 2 shots, etc., you're going to see your side effects. It's very rare to have them after that, and so it looks very well. It looks good. We also don't know yet. We haven't looked at the data being published. This has all been press release data, whether it prevents severe, asymptomatic cases, high-risk cases, and this one is now looking at children 12 and older. Pfizer is doing that. They didn't do that in the original group. So we are very interested to see all of the answers to these questions. It doesn't mean it doesn't do these things, but we just haven't seen the data yet. Okay. That is peculiar. This thing is going the wrong way. Sorry. Okay, here's Pfizer. Okay, here's Moderna. Okay, also, messenger RNA. Look at the efficacy on this one, 94.5. It's hard to believe. It's too good to be true, you know what I mean? But it's very good. I mean, I'm not going to fight with it. The storage is less problematic for this one. It's a -20, which is your refrigerator freezer. You know, then you can keep it in there for a while. Seropositives were allowed to enroll, which I think was great because this looks at how did someone who once had this now do in terms of antibody? They have their baseline, and then they have what happens after this. And do they have any worse side effects because of that? So they're looking at all of those things. I thought that was good. They did have several severe cases, but all of them received placebo. So Pfizer's severe cases, I didn't mention, they had 9, and one of them had received actual vaccine. So this one's actually better, I mean, on this small numbers so far, but better in terms of preventing severe. The questions again, long-term safety, asymptomatic people, efficacy in elderly and high-risk ethnic groups, and children. They didn't study any children at all, so we still need to know that. Okay, this one's a little bit more controversial that many of you may have heard about the controversy on AstraZeneca. It's a harmless adenovirus that is not with messenger RNA, but the genetic code for spike protein was established, and it is put in there, so it's called a recombinant vaccine. So they take a harmless chimpanzee cold virus, never affects people, and they stick on this like Trojan horse in there and carry it in. And they've got 23,000 participants in the UK and Brazil. This will save the world. It doesn't need big time refrigeration. It is super cheap. They're not getting any profit. They've actually given up all their profits, only about $3 to $4 a dose compared to $12 to $16 a dose. Remember, you're talking 2 doses again. This one is a month apart. Remember, the others were 3 weeks. It's very easily stored. And the really weird part about it is that they came out with the efficacy, but the efficacy was messed up a bit because the people, 20% of them about, received half strength on dose 1 by accident because it was a manufacturing defect. Not exactly reassuring. They had this manufacturing defect, and believe it or not, as weird as it is, it had 90% efficacy versus 62% efficacy when the full strength, both doses were given. That has to be looked at very carefully because I would like to know, like, was it a different population that had the 62% efficacy? Did they stratify for, age or whatever? But at this point, it's still a mystery. It's still good, 62%, it's nothing to sneeze at, but it's nice if it's 90. So they're doing a lot of trying damage control to have to go through the questions of what in the world went on with that dosing. We still don't know children in this one, and we don't know the best dose, obviously. So I say this will save the world because most of the world can't afford the more expensive vaccines, okay? Most of the world cannot store vaccines easily in a -90 or -7, whatever. You really needed to have something like this. And so everyone's very eagerly awaiting to see what the results really are and whether this one will go quickly. The most common side effects with all of them are injection site pain, fatigue, muscle achiness, joint pain. Typical, when I get a tetanus shot, my arm swells up. I'm miserable in that point, but hopefully I'll get better after icing it or whatever, but it's no big deal, okay? They haven't had really horrendous side effects. I will mention the AstraZeneca's had one death, but that person looked like they were on placebo, okay? They broke the code. The other person had something called transverse myelitis, which is a rare complication of having had viral disease in some cases, and it was associated with the swine flu virus. Many years ago, when we had swine flu virus vaccine pulled from the market because of Guillain-Barré, which is a similar kind of neurological problem. These things can happen after a viral infection, and so it's not unheard of that they would possibly happen with an immune response because they're autoimmune, okay? So, but they're rare, it looks good so far. We don't know whether the one who had transverse myelitis was actually on vaccine. He may very well have not been. We'll know soon though. Okay, this is the myth busting. You cannot get COVID-19 from these vaccines. They are not live vaccines. Yellow fever is a live attenuated. The old polio, oral polio or nasal polio was a live attenuated. People could get things like that from it. Smallpox vaccine, that kind of thing. We're giving cowpox, not smallpox, but none of these are live that we're looking at. They're all looking at either that spike, or they're looking at whole killed, or they're looking in some way or another. They're not looking at live. So, and if you're immunocompromised, it's safer not to get a live vaccine. So these all are fitting the bill right now. These 3, definitely. if you go for a PCR viral test, this will never turn one of those positive, okay? And PCR is standard for looking at whether or not someone has a viral infection like COVID. If you've already had COVID-19, people in the Moderna did, you may still benefit from getting vaccinated. So most of the time you'll either get it less badly or not at all. So we say that even with shingles, even if you've had shingles as an infection, get the vaccine as well, Shingrix. And vaccination can prevent you from getting severely sick with COVID-19. So these are the myth busters, because it always amazes me that people come out with these fears about getting it that are based on, you know, something that isn't happening. It's not a live vaccine. So this is a lineup in the 1950s of children waiting with their parents to get the experimental the experimental polio vaccine, Salk vaccine. And I could be that person right there, you know, I don't know. My mother stood online with me. I remember going. I actually got the real vaccine. And the question was, wait, you want to get it, wait, or you want to get it now for this new vaccine? Normally people will say, well, I'd like to see it out for a year or so, even though I told you that most of the side effects happen within the first few weeks, and there's not much else that can happen unless it's a weird thing like dengue, you know, dengue vaccine. People who got a dengue and get it again get it much worse, so sometimes they have an autoimmune reaction. But there's no evidence to suggest that would happen here. Me, I would not wait. You have a worldwide pandemic. You have economies crashing everywhere. This is not a wait situation, especially if it looks as good as it does now. I would not wait. I just tell you my personal opinion. And I did not wait for that one. I didn't have a choice, but I didn't wait for that one either. Okay, so vaccine distribution, a big going on now of who's getting it first. Currently, the CDC just came out, and the ACIP, these are all doctor organizations, the ACIP. The feeling is that obviously first responders and healthcare workers will get it first. These are the recommendations, and nursing home patients and essential workers. And each state is going to make their own decisions. It's not a matter of the federal government saying this is who should get it first. They are suggesting this, but each state can make their own decisions. Certainly high risk with underlying medical conditions. I got a call today from somebody who had cancer, who said, did I think MD Anderson would be able to get vaccines for them, even though they're not on chemo anymore, but they, you know, are on one of the post-chemo. It was actually breast cancer, so it was tamoxifen. I said, if any place, probably yes, they probably could get it. But there are really only 20 million vaccine doses being distributed in the, I think, third week. If they get approved, third week of December. So that means 10 million people only. And that's in the US, because you're talking about 2 doses per person. So it's not a matter of, you know, should I get it now or later? You may not be able to get it now. My guess is you will not be. And I told her, I said, you're probably going to have to wait till mid-2021, if you're lucky, to get it, even though, you know, you had cancer in the past, but there were an awful lot of people who've had cancer in the past. People 65 and older, she wasn't. And as I said, the general population, probably by mid-2021. So what are the strategies for now? And I want to leave it open for questions. I'm going to move quickly. We have too many kapuna, right? 240,000 are older than 65 in Hawaii, and we don't have enough beds. We don't have enough critical care beds and ventilators. Right now it seems moot because we have such a low caseload, but boy, oh boy, could that explode quickly. We've seen that happen in New York, and we've seen it happen in Seattle and various other places, Germany, and actually Italy, the worst. But the big thing is that you don't want to overwhelm your health system, okay? So whatever you believe about the mortality and whatever you believe about the morbidity, and believe me, there's plenty of it, which means your sequelae after even getting a mild case, not good, you don't want this. You don't have enough beds, okay, for this, and you don't have enough capacity for other emergencies. So you get a car crash, your kid is in a car crash, they're going to the Queen's Hospital ER, and the ER is like a zoo because everybody in there is taking every bed. They're all COVID patients. This is not what you want to have happen in Hawaii. You also need more time to develop new therapies and vaccines. Some of those newer vaccines I mentioned are going to be very good vaccines also, and they're going to be taking a while because of the old technology, okay? So masks, a lot of controversy about masks. There shouldn't be. I would never, ever walk into a room of an infected patient without a mask on. I would never knowingly walk into any place now without a mask on, when even if I thought everyone in the place was completely fine. It was my little circle of friends. Well, I don't know who their little circle of friends are, etc. I just wouldn't do it. We practice social distancing religiously, my husband and I. We're both doctors and we've both seen too much. I haven't been to a large gathering. I haven't been to any major gathering of any kind for over 7 months. And I really feel good about that. Not bad. I'm not going crazy doing it. I'm staying alive. Also, those are things you can do in red. The things that others can do is contact trace very quickly, enforce quarantine rules, and take the vaccine when available. This is a little cartoon here that I can't see because it's covered by all your faces over here. There, bring it down there. There it is. Thank you for not social distancing or wearing a mask. This is COVID talking to you, right? They're very thankful. And protecting your right to catch and transmit fatal infections. And this is a bugaboo of mine. I cannot believe that health protection law in this country has been politicized. It really is dangerous not to do these things. This is not new. People didn't like wearing masks for a long time. This is the 1917-18 flu epidemic, pandemic. And what's wrong with this picture? Well, by process of elimination, it's the nose sticking out of the mask right there. 70 to 80% of all of your germs are coming out of there, okay? So really protect your nose and mouth. Don't walk around with a mask on incorrectly. I see it all the time in Costco. You've got people with the mask below their nose, and it's like I go crazy. I go over and say, please bring your mask back up. They think I work for Costco. I should probably wear a little red jacket, so. Anyway, these two statues are in New York. And they are outside the library in New York, on Fifth Avenue. And these, if you remember, New York had refrigerated vans waiting outside of all of the hospitals for all the bodies during the last surge. They went through hell. And they really, really cracked down and had everyone wearing masks and doing social distancing, etc. And it worked. They did a great job. Unfortunately, there'll be another surge. But this just, the name of these two statues is Patience and Fortitude. And believe me, that's exactly what we need in this situation. So thank you very much. And I'm opening to questions now. I believe there are some chat questions, but I haven't seen any of them because I can't see the chat for some reason.
Okay, this is Ken. You know, I tried sending a, Eileen, you want to take the PowerPoint off the screen?
Yeah, I was just doing that,
Okay.
sorry.
Okay, I tried sending a chat, but it didn't work. So maybe something is going wrong.
Okay.
Oh, I just see one. I see one from Carol Egan. How did the 1917 flu pandemic end?
Okay, it burnt out because 50 million people, the estimate is, died in the world. And it went on for 2 or 3 years. We will not probably have it go that long, hopefully, because we will have vaccine.
Okay, I have a question. You know, kids, relatives are flying home for Christmas and so forth. Even if they get, um, you know, a negative COVID test when they get on the plane, they can pick it up while they're on the plane. So what is your recommendation when they get home about quarantining in our houses?
Well, this is what I've told many people who ask me, including my neighbors. Um, I would stick to the 14 days. And if you have a separate bedroom and a separate bathroom, it's wonderfully if they're downstairs and you're upstairs, etc. That would be excellent. You know, there is GI spread, you know, to keep the lid down whenever you flush because there's a spume of germs that come up. These are the things you have to think about with COVID, but you do not want to share a bathroom if there's any way possible. You also do not want to eat with them. I'm so sorry to tell you, if your kids are coming home for Christmas dinner, I mean, that's not really going to work because you're not supposed to be really eating or being around people who could conceivably carry it. They could go for a post arrival test 5 days later, but it should be a PCR because the other ones, they're so poor in terms of their specificity and sensitivity. I really don't think they work that well. And if there's any real fear at all, I would try for a PCR. I know one of my friends has just come back from the mainland, and he knows how I am. And he said, I got a PCR, I got it at Kaiser, and it'll be done in a few days. We have, you know, a 6-foot separated drink or whatever. I said, well, think about it. I want to see that test result. But anyway, yeah, you could do that. But that should be isolated really for the full 14 days, in my opinion.
Okay, so, but you mentioned that get a PCR test after 5 days. I mean, that doesn't sound like it's foolproof.
Oh, I think it's probably better than just running and saying, what the hell, you know? But if you still quarantine them after that, that's fine. But the 5-day is what I think would be a little safer to say, if I'm not going to do it, or I'm going to do social distancing and masking when they're around and still be able to eat if they're 6 feet away, then 5 days is probably okay. But you're right. I mean, if you want to really be parochial about it, you go the full 14 days, which sort of screws up the whole Christmas visit, right? You've got 14 days of handing them a tray with, you know, the Christmas dinner on it and everything else. It's a crazy situation, unfortunately.
Okay. We got a bunch of other questions in the chat box. If you can look at that, Dr. Hilton.
Okay. Yeah. Okay. So which other companies are close to developing a vaccine? There are 12 in phase 3, and I would have to look at exactly what their names are and give them to you. But right now, there are 12 in phase 3, and I can send you an email if you send me your email and give you all of the names. Okay. Will we need to vaccinate annually like the flu vaccine, or is it a one-time event? I don't know. I mean, you know, that was such an incredible rate of coverage. I mean, it's just 95%. You would think it would last. They need to look at 6 months, at a year, just to see what the antibody levels are. You know, in the immune system, there's antibody levels, there are T cells, and there's something called neutralizing antibodies. They're very expensive to do. I used to do that in the lab I was in. The neutralizing take a long time, and they're expensive and time consuming. But if they determine that they last longer than a year, let me give you the typical lasting times of vaccines. Yellow fever, 10 years. That's damn good, right? Flu, 1 year, okay? Tetanus, 10 years, unless it's a tetanus-prone injury, then it's 5 years. They thought that polio was lifelong. It is not. You need a booster in adulthood, okay? Especially if you're doing international travel. Measles, mumps, and rubella, they thought was lifelong. It is not. You need boosters. and you've seen outbreaks. So it differs. It's based on the actual disease and how good that vaccine is. 10 years is really terrific. And remember when hepatitis A came out, if any of you are international travelers, that was recommended. Hep A vaccine, always get a Hep A vaccine, boost your polio, etc. Well, the Hep A vaccine was supposed to be a lifetime, and it didn't turn out to be. So they're now boosting that as well. So
we got another interesting question about masks after taking the vaccine. You wanna tackle that one?
yeah, I actually just watched Paul Offit, who's like a pediatric infectious disease doctor, speaking on one of the stations that I subscribe to. And he was asked that question, and he said, yes, he would wear masks.
Okay.
Yeah.
Then let's go to the next one, the incubation period.
Where is the question?
That,
I had heard the incubation period is longer than 14 days. How long is it? They've reported cases of 29 days or more. You know, it's kind of hard to know because when did you really pick it up? I don't know if any of you have heard about the app for your iPhone and your phone where you actually can track whether you've ever been exposed to COVID in the last several, whatever. I'm going to get that app and download it. I can send people the app. But if you go to Costco, say, and you're more than 15 minutes near somebody who's actually, because they have the GPS on their phones, right, who actually then test positive for COVID later, this app will notify you that you may have been exposed to COVID. So I don't know if that's of any interest to any of you, but incubation period is usually 14 days or less. They're guessing, okay? It can be longer. Okay, the next one is, do you recommend taking the bus? What are the risks if you wear a mask and avoid touching surfaces in the bus? Would I take it? No. Recommend avoiding taking it? I don't know. If you're wearing a mask and you're being careful and you're staying 6 feet away from people, they usually keep the windows open, don't they? I don't know. I haven't been on the bus here, but they usually keep the windows slightly open. You want to have that air circulating in there, so it makes it less dangerous. Okay, please keep my name private. Please push the need to constantly tell people not to be casual about this virus. It won't hurt me. It's not so bad. My twin brother was infected on life support, coded twice. Oh my God. Yeah, I can't tell you. This is very good. Thank you very much. This is definitely true. You do not want to be casual about this virus. Even asymptomatic. We've got 60% of asymptomatics having on MRIs of their heart myocarditis. That's unbelievable. Okay, so really, this is not a nothing thing. It's not a nothing burger. From errors to everyone. If the current attempts at vaccines are not successful, is there nothing method of prevailing over the pandemic? Pandemics, once you reach a certain point of everyone having died or been infected, burn out. So that's really the other method. Some countries opted to get to herd immunity faster and sort of gave up. Sweden just recently gave up and said it's too scary. Everybody was dying and getting sick and whatever. But that's really it. We're hoping the vaccines are successful. I think they will be. They look very promising. Does COVID-19 mutate? Yep. Would a new vaccine be developed for mutated? Yeah. Okay, so I mentioned that not all of them are targeting the spike. Okay, some of them are targeting the whole organism. And then there were several that it's easy to modulate what you put in, like your little Trojan horse. Okay, so yes, they would develop new ones if it mutated. There are 6 mutations currently. Let's see.
Hey, Dr. Hilton, we had one, somebody has a kidney transplant. Which vaccine should they take?
Yeah, any of them. They're not live. You can take those.
Okay.
Yeah. As long as it's not live, you don't want to give an immunocompromised person, which is anybody who's had a kidney transplant or a bone marrow transplant or was on cancer chemotherapy, any of those things, you do not want to give them a live vaccine. Can you send us a link to print the information? Sure. Whoever wants the link, email me at ehiltonmd@gmail.com. Okay? And I think that's it. Are there any other questions? Nope.
No, so tell us about the best pastrami sandwich in the world.
Okay. Well, it's a dive. I mean, it is really a dive.
It's not a dive.
It is a total dive. I don't know what they did on the west side, but the one on the east side was disgusting. It's called Pastrami Queen, and it's phenomenal. The pastrami is perfect, and they also have good pickles. So, but you'd have to wait at that one. There's like usually a line, and it looks like a takeout place, and you wait to get a table. If you just want to take out, you can just wait online and take out, but it's pretty much a line. I understand that now on the west side of Manhattan, they just opened a new one, Pastrami Queen, and in the middle of COVID epidemic, it's quite amazing that they're doing well, and they are. I tried to buy some of their stuff by going online. It was so overpriced, I couldn't do it. I couldn't push the button and say,
Yeah.
hey.
It's a typical Jewish deli.
Yeah.
That you don't find here, and it's really, really good. If you look it up, Zagat rates it as the best pastrami in the world.
It probably is.
It probably is, yeah.
Yeah,
It's
yeah.
really, really good.
Yeah.
So
Recommendation of a patient.
hey, what can you give your email address again?
Sure. Hilton, EHILTON MD@gmail.com.
Okay, if you still don't get it, you can email me, ken@kenwonglaw.com, and I can get it to you. Okay, I think that's it. So everybody, thank you for plugging in. Oh, wait. One last question from Gilbert Doles.
Mm-hmm.
Would outdoor dining for lunch with a small group of 5 be safe in your opinion?
I don't do it. If you want to do it, it's allowed. That's all I have to say. I certainly think sitting right next to someone else at a table, is not great. What can I tell you? You don't know who's got it. It's so much asymptomatic spread. That's the only thing I can tell you. And I have it set up so if someone came over to my house, which hasn't happened in months, by the way, just in case, I have a 6-foot table that my husband and I would sit on one end and whoever was on the other end. So it's 4 people max. Okay. So I haven't gotten to the 5 people yet because I can't figure out how to seat them. But neither have I gotten to the 4 people yet because I'm too chicken to do it until I see a vaccine in hand, so to speak. So thank you very much, everyone. And there are no further questions. That's it.
Yeah. Thank you so much, Dr. Hilton. And I guess when the vaccine gets more widely distributed, we will know how long it will protect us.
Yeah, I hope it's more than a year, but even if it isn't, that's still okay.
Yeah.
It's still okay.
Okay.
Okay. Take care, everyone.
Thank you, everybody.